I'm Mike Grunwald. I'm happy to be here today to talk about stem cell transplant approaches to myelodysplastic syndromes. So the number of transplants performed in the United States is increasing in general, and the number of allogeneic transplants as depicted by the green line is increasing every year. Now, allogeneic transplant is the only established therapy for myelodysplasia with curative potential, and today I'd like to address three questions. Which patients should undergo allogeneic transplant? What is the appropriate timing of transplant? And how should transplant be performed? And there are multiple questions within the last one. Myelodysplasia and myeloproliferative neoplasms, which are lumped together in this analysis, now together form the second most common indication for allogeneic transplant. They've surpassed acute lymphocytic leukemia and are second only to AML. And the number of transplants for myelodysplastic syndromes in particular is increasing every year, especially over the past 4 or 5 years. There have been a lot more transplants for this indication. Long-term survival settles out around 50% for most patients undergoing transplant. And this is a retrospective CIBMTR analysis looking at patients receiving HLA matched sibling transplants for MDS. And the patients are broken into two groups: early MDS, which in this analysis was FAB, refractory anemia, and RARS patients. And the advanced group consisted of patients with RAEB1, RAEB2, and CMML as well. And early MDS patients consistently do better with transplant than the advanced patients. And this is also shown here when unrelated donors are used, that the early MDS patients do a bit better than the advanced patients, with average survival settling out somewhere between 40 and 50% long term. And survival has been improving in recent decades. Over the past 2 or 3 decades, there's been steady improvement in survival with transplant for this indication. This is another depiction of the same data, and you can see that from 1988 to 2002, 1-year survival for MDS patients undergoing allogeneic transplant, and this is just unrelated donor transplants, was 42%, and now the survival at 1 year is closer to 62%. 2-year survival was 36% in the older time period, and now is about 49%. So there have been improvements over time, and most of that, I believe, is attributable to improvements in supportive care with transplant. So there are two anti-tumor components to the transplant. One is the conditioning regimen. The other is the graft versus tumor or graft versus leukemia effect, sometimes called the allo effect. And the allo effect is the more important component, in my view, of the transplant. However, we still use a conditioning regimen. And the conditioning regimen has 3 goals. One is immunosuppression of the patient so that there's not graft rejection. The second is cytoreduction or a debulking effect. And the third is to create stem cell space. The graft versus leukemia effect is important in killing the stem cells in myelodysplasia, and myelodysplasia is intermediate in terms of hematologic malignancies, in terms of its ability to be fought off by transplant. It's not as susceptible to the allo effect as CML, however, it's more susceptible than some other diseases, including ALL. Now, donor selection is a major issue in allogeneic transplant in general and in myelodysplasia in specific, and only about 25 to 30% of patients have a matched-related donor available for transplant. And we have a number of alternatives now, including matched unrelated donors, single mismatch unrelated donors, haploidentical relatives, and umbilical cord blood. And this is a CIBMTR study that shows that patients who are receiving transplants with matched-related donors or with 8 out of 8 matched unrelated donors do better than patients with 7 out of 8 matches for transplant. And this is not because of differences in relapse among the groups, it's because of an increase in non-relapse mortality in the patients who have a single mismatch MUD. Now, haploidentical transplants have been a hot topic in the tandem meetings every year and also at ASH recently for about the past 5 years. And we're only starting to gather data in myelodysplastic syndrome patients receiving haploidentical transplants. This is the largest study of these patients. It's retrospective from a Chinese registry, and this study looks at survival in patients undergoing transplant from haploidentical donors versus identical siblings. I mean, not identical twins, but matched siblings. And the matched siblings performed better in this study. However, everybody overall performed very well. And I think that the reason that this study overall had very good results in terms of survival had to do with the fact that this was a very young population that included some pediatric patients. The average age on the study is about 30 or 35, and better results were shown with match-related donors rather than haploidentical donors. However, haploidentical donors still had better than usually seen long-term survival. And so the conclusion from this study is that a haploidentical donor might be an acceptable alternative when a match-related donor is not available. Now I'd like to talk briefly about sources of hematopoietic stem cells. We have 3 main sources of stem cells. One is peripheral blood stem cells. The second is bone marrow. The third is umbilical cord blood. In the United States, most often is used peripheral blood progenitor cells. And with peripheral blood stem cells, we see faster engraftment and also larger numbers of T cells in the peripheral blood stem cells might result in higher rates of chronic graft versus host disease, which is the downside of using peripheral blood progenitor cells compared to bone marrow. Many factors can affect engraftment in patients undergoing hematopoietic transplantation. Host factors include disease effects, sensitization, immunosuppression, conditioning regimens, and post-transplant therapy. And donor effects can include the donor source, the stem cell dose, T cell dose, stromal stem cells, and graft facilitating cells. And histocompatibility, which pertains both to the donor and the recipient, is a very important factor as well. So what is the current status of allogeneic transplant in myelodysplasia? Transplant's considered as an option in fewer than 4% of MDS patients in the United States. And one of the big issues is that myelodysplastic syndrome is a disease generally of older patients. The median age at diagnosis of MDS is greater than 65 in almost all published series, and sometimes much older. And how do we overcome this problem? We can't perform a myeloablative transplant in patients who are over 65, or at least can't do it safely. And if much of the benefit from transplant is due to a graft versus leukemia effect, then we might be able to circumvent this problem by using less aggressive conditioning regimens to prepare people for transplant. And so 2 or 3 decades ago, investigators developed the hypothesis that myeloablative therapy might not be necessary, and that lower dose conditioning regimens might prevent graft rejection and also may reduce toxicity, extending transplant to older patients with myelodysplasia and other diseases. So just to review, myeloablative conditioning causes irreversible pancytopenia, requires stem cell support. And reduced intensity conditioning takes this down a notch. It causes significant and prolonged cytopenias, also requires stem cell support, and it's characterized by a reduction in the alkylating agent or total body radiation dose. Non-myeloablative transplantation is characterized by less severe cytopenias, and most of the time, patients would have autologous recovery without stem cell administration following transplant. So, and this is another CIBMTR slide showing that younger patients under 55 years of age, perform better with transplant than patients over the age of 55. However, among the group over 55 years old, patients who undergoing myeloablative conditioning perform about the same as patients who undergo reduced intensity or non-myeloablative conditioning. And the fact that patients can do well with reduced intensity or non-myeloablative conditioning gave rise to the question whether we can do away with myeloablative conditioning altogether. And this is from the BMT-CTN 0901 study, which was presented by Dr. Scott at ASH this year. It was a phase 3 study enrolling 54 patients with myelodysplasia, 218 patients with AML, so it was predominantly an AML study. And it set out to ask the question whether myeloablative conditioning could be replaced by reduced intensity conditioning in MDS and AML patients who were eligible for myeloablative conditioning. This study ultimately suspended enrollment because the reduced intensity regimens resulted in higher relapse rates than myeloablative regimens. And I would like to point out that the relapse-free survival for patients receiving myeloablative conditioning versus reduced intensity conditioning was 67.7% versus 47.3%, so a pretty significant difference in relapse-free survival in these two populations, which again included both AML and myelodysplastic syndrome patients. At 18 months, survival in the myelodysplastic syndrome population was 81.5% with myeloablative conditioning, 85.2% with reduced intensity conditioning. However, the relapse rate was much, much higher in MDS patients who received reduced intensity as opposed to myeloablation. And so I'd like to change gears for a moment and talk about which patients are likely to benefit from allogeneic transplant, which to me is the biggest question in this field. And I'd like to start with a patient case, 64-year-old African-American male who was noted on routine physical examination or routine physical visit to have new onset of leukopenia. His blood counts were white blood cell count at 2.4 with a neutrophil count that was low at 1,000. Hemoglobin was normal, around 13.6, and his platelet count was 144. He was observed, and 1 year later, his ANC was still 1.0. However, his platelet count had dropped to 105. And he underwent a bone marrow examination revealing 7% blasts. He remained asymptomatic. So we were left to decide what to do: observation, start treatment with a hypomethylating agent, or perform allogeneic transplant. And we will come back to this patient in a moment. So Dr. Scott already alluded to the two decision analysis studies, and the first study by Cutler and colleagues was performed in 2004, and this is a retrospective Markov model to determine whether survival was better in patients undergoing transplant versus non-transplant therapies in low, intermediate 1, intermediate 2, and high-risk IPSS scores. And in the group with low and intermediate 1 scores, patients' life expectancy was longer with non-transplant therapies. In the low-risk group, for example, we see average survival life expectancy of 7.2 years in the patients who were transplanted at disease progression versus survival of 6.5 years in patients who underwent immediate transplant. Now, in the intermediate 2 and high-risk groups, the opposite was true. Patients performed better with immediate transplant as opposed to transplant at disease progression. And in the second decision analysis, which is a more recent study by Dr. Korath and colleagues, we see that this really holds up in the 60 to 70-year-old age group with patients undergoing reduced intensity transplants. And in the low and intermediate 1 group, non-transplant therapies were favored, both in terms of life expectancy and quality-adjusted life expectancy. And in the intermediate 2 and high-risk IPSS groups, patients were expected to perform better if they underwent transplant early. Now, the CIBMTR also recently set out to look at prognostic factors in patients undergoing transplant for myelodysplastic syndromes and identified a number of unfavorable features, including a high-risk karyotype, especially monosomal karyotype, for which you get 2 points. Older age, so age greater than 50, scored 2 points on the scoring system, and age 30 to 49, 1 point. Circulating blast greater than 3%, platelets less than or equal to 50, and performance status, Karnofsky performance status less than 90. And with these numbers added up, you can arrive at a score for each patient, a risk score, and this will help determine the expected survival for patients in that risk group. This study, it's important to note that this study doesn't tell you which patients to transplant. It does allow you to have an educated discussion with patients about what their expected survival might be in their risk group. So it allows you to help them with the decision about whether to undergo transplant. And this is just the Kaplan-Meier curves associated with that data, showing that this scoring system held up in both the training cohort, which was the HLA matched cohort, as well as the testing cohort, which was the mismatch, HLA mismatch group. Therapy-related MDS generally has a very poor prognosis. However, there are some long-term survivors with allogeneic transplant, and I think that that's important to note. I'd like to mention that hematopoietic cell transplantation is likely underutilized in myelodysplastic syndrome. We talked a moment ago about how high-risk patients might do better with upfront transplantation and how most lower-risk patients should not be transplanted upfront, but maybe should be transplanted when they exhibit disease progression. In patients who fail azacitidine, hematopoietic cell transplantation is associated with better outcomes than non-transplant strategies, and this is the study we saw earlier by Dr. Burbet et al. Now nearly every patient has a donor for transplant with the advent of haploidentical transplantation and umbilical cord transplants, and now we can extend transplants to older and less fit patients with reduced intensity and non-myeloablative approaches, and so we should be seeing more than 4% of patients considered for transplant. So there's been some study of why transplant is underutilized and patients aren't referred very much for transplant. One is that the efficacy is underestimated. Another is that sometimes when patients are treated with hypomethylating agents, they'll exhibit a downstaging or an improvement in their IPSS score, and therefore transplant won't be considered at that point. There's the impression among some physicians that hypomethylating agents can cure patients' disease, and we learned why that's not the case yesterday morning in our lecture. Patients and physicians are sometimes unaware that transplant can cure MDS. Baseline quality of life is not taken into account, generally speaking, in determining whether patients should undergo transplant, and maybe it should be. There's long been trouble with reimbursement for patients with MDS who are considered for transplant. CMS has had no national policy regarding transplant. However, since 2010, Medicare covers transplant for MDS patients who are in an approved clinical trial. One of these trials is the BMT-CTN 1102, which is setting out to compare reduced intensity transplantation with non-transplant therapy. It's including patients 50 to 75 years of age with intermediate 2 and high-risk MDS, and they're biologically assigned to transplant or non-transplant therapy. And a similar study is ongoing in Germany where patients 55 to 70 with higher risk myelodysplasia are undergoing biologic assignment to azacitidine, followed by hematopoietic cell transplantation. So at ASH last year, a CIBMTR study compared patients over the age of 65 to patients in the 55 to 65 age group, and 2-year survival was very similar among these two cohorts, suggesting that it's safe to transplant patients, at least selected patients, who are over 65. And in addition, another group set out to answer retrospectively the question of whether azacitidine versus transplant is a better approach in higher risk MDS or secondary AML patients 60 to 70 years old. And this study included patients from Germany, France, and Seattle. 103 patients underwent transplant. 75 patients who either didn't have an available donor or in whom transplant was not considered by their physician were also included in this group. And what was noted was that 2-year survival with azacitidine was 23%, and 2-year survival with transplant was 39%. And these are the Kaplan-Meier curves. On the left is overall survival, on the right is event-free survival on this study. So So neither are great-looking curves, but possibly better with transplantation. Now, what about azacitidine as a bridge to transplant? This was a phase 2 study of 93 patients in Italy looking at patients receiving first-line therapy with azacitidine, and then with a goal of undergoing allogeneic transplant. Patients received a median of 4.5 cycles of azacitidine. 52% of patients underwent transplant. Disease status after receiving azacitidine was predictive of improved survival in this population. And I think that's the take-home point from this study, that patients who achieved CR did better than patients who did not, with patients achieving either partial remission or hematologic improvement in between. What to do with patients who relapse following transplantation? This was a study looking at donor lymphocyte infusion plus azacitidine in this population. MDS patients achieved a 41% CR rate with this therapy. And in the last few minutes here, I'd like to look at guidelines for patient selection that can also help us look at this issue of which patients to perform transplant in. So these are the European Leukemia Net 2014 recommendations for IPSS-1 MDS patients. And the Leukemia Net recommends that for patients with bone marrow blasts greater than 5% or poor risk cytogenetics, and with an available stem cell donor, that allogeneic transplantation is considered. And then for IPSS-2 or high-risk patients with an available stem cell donor, allogeneic transplants also recommended, especially in patients who are less than 65 to 70 years old. And patients with high blast counts, greater than 10% bone marrow blasts, are recommended to undergo cytoreduction with AML-like chemotherapy or azacitidine prior to transplantation. The ASBMT recommendations for which patients to refer to transplant include any intermediate or high IPSS or IPSS score patient, any MDS patient with poor prognostic features, including therapy-related MDS, refractory cytopenias, adverse cytogenetics, transfusion dependence, or failure of HMAs. And then the NCCN recommends upfront transplant in higher risk patients with an available donor, and it's acceptable to administer therapy prior to transplant, but transplant should not be delayed due to the administration of hypomethylating agents in this group. Selected intermediate 1 patients are recommended to undergo transplant if they've progressed on previous therapy. And so getting back to our patient's case, he was intermediate 1 risk by IPSS, low risk by IPSS-R. He was monitored with observation initially. However, 1 year later, his ANC dropped to 0.6, his platelet count dropped to 74, bone marrow revealed that his blasts had increased to 17%, his fission cytogenetics remained normal. Now he was intermediate 2 by IPSS and high risk by IPSS-R, and we reviewed his treatment options. A donor search was performed. He did not end up having a matched related or unrelated donor, and he was initiated on azacitidine with clearance of his blasts. And with his blast cleared, he underwent a non-myeloablative haploidentical transplant from his daughter, and he's now 15 months out, and he has a ANC of 3.0, hemoglobin 13.6, and platelet count of 165, with some mild skin graft versus host disease. So in summary, the key points are for higher risk myelodysplastic syndrome patients under 60, we would consider upfront myeloablative transplant. For higher risk patients in the 60 to 70 age group and in carefully selected patients over 70, consider upfront reduced intensity transplantation. Do not delay transplant in higher risk patients who are responding to hypomethylating agents. For lower risk patients, I would consider pursuing non-transplant strategies first and consider transplant upon disease progression. I would consider transplant in patients who have failed hypomethylating agents. And for post-transplant relapse, would consider azacitidine and donor lymphocyte infusion. Thank you very much.